Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. During these extraordinary times, when everyone is busier than ever, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As part of this briefing, we'll have an opportunity for live Q&A with our experts, and we'll be offering these 30-minute briefings regularly on Fridays at 12 p.m. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. I'll moderate these briefings, and I'm excited to connect you with our experts. We'll be providing answers in real time, so please submit your questions in the box at the bottom of your screen. Today, I'm joined by two guests. Dr. Jennifer Nuzzo is a senior scholar at the Johns Hopkins Center for Health Security and an associate professor at the Johns Hopkins Bloomberg School of Public Health. Jennifer will give us an update about trends we're seeing within the COVID-19 data. Dr. Bill Moss is executive director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update on vaccine development and policy responses. Jennifer, we continue to see increases in new cases of COVID-19 as well as deaths. These trends are, of course, incredibly troubling. What do you think it's critical for us to be paying attention to right now?
Well, unfortunately, yesterday brought very disappointing news in the sense that we broke all-time records for the number of cases and deaths being reported in the U.S. So yesterday, more than 217,000 cases were reported across the entire country, and we've never seen that many cases in a single day. Nearly all states are reporting record high case numbers as of this last week. And, a number of states are seeing really large increases. And as you mentioned, deaths are also increasing across the country, breaking records set early in the pandemic. So yesterday, we really saw deaths for the first time approaching 3,000. It was just over 2,800. And this is the highest ever recorded in the history of this pandemic. This is not something that we can explain away, as some try to do, as an artifact of all of the testing that we're doing. The test positivity, which is something that we look at to get a sense of if the U.S. is doing enough testing, is also reaching an all-time high. It was more than 10% yesterday, 10.7%. We haven't seen this kind of test positivity since the spring, when testing was severely constrained. And I would argue it's probably not even comparable in the situation where we have been consistently doing 1.5 to 2 million tests per day. We've never seen a test positivity over 10% in the US. So really, I think a worrisome trend. And what this suggests, and I don't know if there's a slide that we can pull up just to see, is that despite the massive amount of testing being done in the US, the virus has outpaced those efforts. And so what we should take away from this is that because this virus is spreading so quickly, we must do even yet more testing in order to find infections. And when we have really high test positivity, it does increase worries that we are, in our case numbers, not capturing everybody. We know we're never going to find all of those people who are infected and don't know it, but as test positivity increases, it increases our worries that our case numbers are an underrepresentation of the amount of infections that are out there. It just means that we are testing the sickest of the sick. So that is quite a worrisome thing. There's another slide that shows, and I'm sorry, I can't actually see it here, but there's another slide that should show the trends, the positivity trends in different states. And as you can see from that, positivity is increasing in nearly every state. So what that means is that all states are going to have to work harder to further expand testing. And when you have a situation where all states are working harder. That does raise questions about their abilities to continue to do that, because access to supplies then becomes an issue. We're already hearing some reports about states, really having difficulty getting supplies and experiencing delays as a result. And so this is really something that we should be looking at in the coming weeks. I've often been asked about Thanksgiving and the upcoming holidays, and I will say that it is too early to see the effect of Thanksgiving. We usually see a rise maybe 3 to 4 weeks after an event like that. So it is too early. And the fact that we are experiencing these record highs before we're likely to see the start of the Thanksgiving effect in our data, I think is a really worrisome signal. And then, of course, that's not the only holiday that's coming up. And so with the amount of travel and likely gathering that occurred over Thanksgiving, and anticipating that that could continue in the coming weeks with the larger holiday season, there is really worries about that the kind of very steep growth in cases and deaths that we've seen across the country could continue.
Thanks so much, Jennifer. And for those who want to see the visualizations that Jennifer was referring to, they are all available at coronavirus.jhu.edu/testing. Before I turn to Bill, I want to remind our audience to please submit questions, and we'll be sure to have our experts answer them live during this briefing. Bill, folks continue to view the promising news about COVID-19 vaccines as a real bright spot. And we're now hearing about several vaccines that appear to be effective, and there's even the potential for FDA to issue its first emergency use authorization for a COVID-19 vaccine. Can you talk us through these recent developments, please?
Yes, and thanks, Lainie. And this is truly exciting and astonishing findings that we're hearing about, particularly with the two front-runner vaccines, the one made by Pfizer and the one made with BioNTech and the one made by Moderna. These are both messenger RNA vaccines, and both companies have submitted applications to the Food and Drug Administration for emergency use authorization. What's really astonishing is the reported efficacy of these vaccines, about 95%. And the fact that we're discussing the potential availability within weeks of a vaccine that has 95% efficacy against this disease, again, less than a year after we first even recognized this pathogen, is truly remarkable. This past week, people have heard that the United Kingdom has issued an emergency authorization for the Pfizer vaccine. After review, there has been limited approvals of different COVID-19 vaccines, both in Russia and in China, but the UK emergency authorization was really the first formal approval in a European or American country for the use of these vaccines. So what's going to happen next in the United States? Well, currently, right now, scientists at the Food and Drug Administration are poring over the data that's been submitted by both Pfizer and Moderna from their phase 3 trials. Remember, those trials are not yet completed, but we've reached a mark that meets the FDA guidelines, where about half of the participants have at least 2 months of follow-up. So they're reviewing those preliminary findings from the phase 3 trials. And then what we anticipate is that on December 10th, a subcommittee called the Vaccines and Related Biological Products Advisory Committee will hold a public hearing about the Pfizer vaccine, and we expect shortly after that the FDA would authorize the vaccine, assuming there are no surprises. And then a week later, the Moderna vaccine's about a week filed their application about a week later. So around February 17th, we expect a very similar review by the Vaccines and Related Biological Products Advisory Committee of the Moderna vaccine. Assuming the FDA authorizes these vaccines for this emergency use authorization, we expect to get recommendations from the Advisory Committee on Immunization Practices that would be endorsed by the CDC, and then we're ready to go. And what we're hearing is that the vaccine doses from both companies are really ready for distribution within days after the approval, authorization, and recommendations are made. So who's going to get the vaccine first? Well, we've learned this week, a lot happening this week, from the Advisory Committee on Immunization Practices and the CDC that they are prioritizing in what is called phase 1A, healthcare personnel, of which there are about 21 million in the United States, and residents and staff of long-term care facilities, such as nursing homes, of which there are an estimated 3 million people in the United States. Those are going to be the first groups, according to the federal guidelines, on who can get this vaccine. Phase 1B includes additional essential workers, and phase 1C, adults over the age of 65 and those with high-risk medical conditions. Now, these are federal guidelines and recommendations, but where the rubber really hits the road here is at the state and local levels. It's going to be the states that actually determine how these vaccines will be distributed within the states. And the ultimate decision is really going to be made at a very local level about who gets the vaccine within a particular healthcare system, for example. We anticipate that the CDC will be distributing or apportioning vaccines to the states proportional to their size. It's anticipated that by the end of this month, there should be just over 40 million doses from these two manufacturers available for use in the public for these high priority groups. That's roughly 20 million individuals. Remember that for each of these vaccines requires 2 doses several weeks apart. We can anticipate perhaps another 40 to 50 million doses in January, and then maybe 50 to 60 million doses in February and March. That's assuming that the manufacturing processes all go smoothly. We know from history that there can be contamination of batches, for example, and those batches need to be discarded, and that will delay the allocation of these vaccines. Lastly, there's been a lot in the media around side effects of these vaccines, what we call reactogenicity. This is local soreness, headache, fever, muscle aches, joint pains. All of these are a sign of the inflammation in response to the vaccine. Some people have had fairly moderate side effects. Some of these are similar to what adults may experience following an influenza vaccine, or particularly following a shingles vaccine, where we tend to see more of this inflammation or reactogenicity. But people should expect these types of signs and symptoms, these signs of inflammation after vaccination, but these are transient. They're lasting maybe 12 to 36 hours. They will go away. Some people may lose a day of work. But I want to reassure the public that these are anticipated side effects. We see these with other vaccines, and they are transient, and in my view, well worth the benefits that's potentially conferred by these vaccines.
Thanks very much, Bill. I'm told that we're having some technical difficulties with the live Q&A, but we do have questions that were submitted in advance. So I'm going to switch to those right now. And to our audience, please keep your eye out for our Q&A box. We are anxious to answer your questions in real time today. Bill, first question is for you. And this is one that I also hear quite a lot. I'm sure you do. So now we have these 2 vaccines that are on the cusp of receiving an EUA. Why is it important for other companies to continue developing COVID vaccines?
Yes, this is a really important question, Lainie, and there are a number of reasons why. First of all, we're going to have a global need. We do have a global need for these vaccines, and it's just not going to be possible for 1 or 2 vaccine manufacturers to supply the global market and meet the global demand. So we need multiple different types of vaccines to meet that demand. Second is that these vaccines, which have remarkable efficacy in these phase 3 trials, may not be the most ideal vaccine. For example, these vaccines require 2 doses. The ideal vaccine would be a single dose that confers long-term protection. 2, these vaccines require pretty strict cold chain requirements, particularly the Pfizer vaccine, which needs to be kept at -70 to -80 degrees Celsius. The ideal vaccine would be much more thermostable and could be stored for long periods of time in a refrigerator. Third, we don't yet know which vaccine is going to be best for certain subpopulations. For example, there may be a vaccine type that's really works best in older adults, or works better in children, or works better in people with certain underlying medical conditions. So there are a number of reasons why we need to continue to explore and develop new vaccines so that we meet the global market and really have the ideal vaccine for different subpopulations.
Thanks, Bill. Jennifer, question for you about testing. So for those that are out casually or driving around, they notice that there seem to be longer lines than ever at testing sites. Can you speak about testing capacity and you know, what are those lines really telling us about testing at this point? Jennifer, I think you're muted.
Sorry. I think two things are happening. One was, I think a lot of people probably went to go get tested before the holidays, which, you know, I think given an anticipation that people would travel and gather despite public health recommendations not to do so, it's probably good that people had some level of information about whether they were infected on the day that they were tested. We, of course, you know, caution people that that's a snapshot of a single day, and that it's not necessarily a clearance that they're going to be fine when they actually see their family. But nonetheless, I do think that right before the Thanksgiving holiday, there were people who might not have otherwise getting tested. But also the case numbers and the level of infection that's in the community is much higher. And so the demand for testing is also greater, which is something that we anticipated just given where the case numbers have been going. And given that there are also other testing that's going on for safety purposes, screening testing and surveillance testing that's being done, such as, by large employers, et cetera. So there is really worry that the capacity might be fixed and that we could yet again see the severe delays that we saw earlier in the summer. I know a number of states have suggested that it's getting harder to get the supplies that they had been getting, in particular because now it's not just a hotspot in one area of the country or a few states. It's all states at the same time needing to increase the amount of testing that they're doing. And the kind of fixes that we put into place to address the shortages in testing supplies weren't really permanent fixes. They didn't, revolutionize our ability to test. They were sort of stopgap measures. And I think this really raises worries about if we'll be able to continue at the pace that we're going at.
Thanks, Jennifer. And I'm told that our Q&A module is now coming online. I apologize to our audience that we had some technical difficulties. You may need to refresh to be able to access it, but please do submit your questions. As I said, our experts are anxious to answer them during this briefing. In the meantime, while we wait for live questions to come in, I'm going to switch back to some of the ones that we received in advance. Jennifer, for you. So for those that are living in communities now that are particularly hard hit, especially in terms of new cases rising every day, what do you see as the most important public health metrics that people should be looking at to understand what's really going on in their community right now?
The things that I spend the most time looking at is I look at test positivity as a measure of the response. Are we doing enough? Are we missing cases? How many, is the amount of cases that we're missing increasing? I think that I found to be a kind of an earlier indication of when we will start seeing the big case increases. But also you need to look at the case numbers, and particularly the daily case numbers. Now, they fluctuate on a day-to-day basis, and some of the kind of data over the last week may have fluctuated more than usual due to the holiday. Sometimes that there are kind of batching of testing and other things like that give you kind of day-to-day dips and peaks. But if you want to get a sense of the trends, I at least look to sort of a 7-day running average to tell you what's happening this week, and then at least a 2-week average to tell you what sort of trends are occurring. I think it's important when you're looking at either case numbers or test positivity to look at the direction of those numbers more so than the absolute number. And I say that because I did mention that there is a sort of recommended sort of 5% benchmark, but it's not a magic number. If the test positivity is below that, but it's still increasing, that should be a signal, a worrisome signal that would prompt states to want to think about going out and doing more testing, because there may be some hotspots that are occurring that may benefit from additional testing. So look at the trends in the numbers, use more than, at least a week's worth of data or two to get a sense of the trend, and look at cases and tests. And then I think another indicator that we are deeply worried about is hospitalizations, because, that will influence whether our death numbers increase. Over the summer, there was some cautious good news that the percentage of cases that were occurring that were dying seemed to be decreasing. But much of those gains that we saw over the summer in terms of improved survival of COVID is likely dependent on there being sufficient capacity in the health system. So that's why everybody is also talking about hospitalizations and really worried about trends there. And if doctors and nurses are unable to provide the kind of care that they have been providing as of late, we would expect to see a greater percentage of cases resulting in deaths. We would also be worried about people dying from other causes that would otherwise benefit from care, but that people not able to receive that care, might experience mortality.
Thanks, Jennifer. And as a follow-up to what you just said, a question that many of us are asked is there one key thing to keep an eye on? And what I would take away from what you just said is that there's really not one key thing. It's sort of keeping an eye on the whole, but would you answer that question?
Yeah, I mean, I think it's common in epidemiology that we look at multiple metrics at once and we sort of triangulate our way to the truth. And it is also common to see worrisome signals in some metrics and not in the others. And it raises questions about why that is sometimes. And sometimes there are good reasons and sometimes they're just, statistical changes. But generally speaking, you have to look at a bunch of different things to understand what's going on. And, I think another important thing to keep in mind is just that it takes time for the data to change. And so you may see a dip one day and it may feel reassuring, but you really have to look at multiple days and weeks worth of data to get a sense of what trajectory we're on.
Thanks, Jennifer. I want to tell our audience that our Q&A module is up and running. Again, apologies for the technical difficulties. Please do submit your questions. We're keeping an eye on them right now. As those live questions come in, Bill, I want to return to you and a question that we received in advance, which is, what do we know about COVID-19 vaccines and pregnant women?
Yes. So this is a really important question, and the short answer is we don't know a lot yet. And there's a much broader discussion that's been going on for a long time about, how best to study vaccines in pregnant women and how to make sure that pregnant women get the vaccines that they need and that they're safe. So we do know that pregnant women, there was a report issued by the CDC, are potentially at greater risk of severe disease and adverse birth outcomes, stillbirths and premature deliveries. So that's of concern. And so we also, in the phase 3 trials, pregnant women were excluded from participating in the trials. But we also know in very large trials such as this, where we have tens of thousands of participants, that women will get pregnant during the phase 3 trial. So it's going to be very important going forward to understand whether there were any adverse pregnancy outcomes associated with vaccination. I'll say that's a very difficult thing to determine, but it can be determined in phase 3 trials. It's very important that that as the vaccine is rolled out, that we collect all the information that we can on vaccination during pregnancy. And ultimately, it comes down to really weighing the risks and benefits of vaccination during pregnancy. So it's a very difficult, complex issue for which there's a long history, and we don't have all the answers yet, but we certainly want to make sure that pregnant women are protected if the vaccines are safe during pregnancy because of a potential increased risk, both for the woman and for their developing fetus.
Thanks, Bill. And I'm pleased to say that our live Q&A are up and running, so I'm going to switch over to questions that we are receiving in real time. Jennifer, a question for you. What is the single most important thing that you would advise people to do right now as they go about their daily lives?
I mean, really, it's wearing masks and keeping distance. Those, I think, are the important things. The same things that we've been saying otherwise. And the need to do that now is greater. As the amount of infection that's occurring in the community increases, the probability that you'll run into somebody who is infected with COVID has increased. And so now is the time to be extra cautious, using your masks if you have to go out and be around other people, but to the extent that you can try to avoid people outside of your household, the better.
Thanks, Jennifer. Bill, question about being able to spread the disease even after receiving a vaccination. So for someone who gets a vaccine, say in the earlier part of the rollout, can they still spread the virus to others who have not yet been vaccinated?
Right, Lainie, and this is a really important question too, and obviously has big implications for the impact of a vaccination program on the pandemic. Here's what we know and what we don't know. First, the phase 3 trials for the Moderna and Pfizer vaccines had as their primary endpoint COVID-19 disease, whether that's mild, moderate, or severe. They weren't designed to look at this important question of transmission. We do know, and we've heard some preliminary results from the AstraZeneca trial. That's a very different vaccine. That's a chimpanzee adenovirus vectored vaccine. That they did seem to detect a signal that the vaccinated individuals had a reduced incidence of asymptomatic infection. Now, that's not a direct measure of transmissibility, but I would say if the vaccines reduce asymptomatic infection, that it's very likely that they're also having an impact on transmission. So what's going to happen? Going forward, I think we're going to need to continue, obviously, to follow individuals in these phase 3 trials, get any evidence we can of the impact of the vaccine on transmission. Again, that's not a primary outcome of the Pfizer and Moderna phase 3 trials, and we're going to need to set up additional studies. People are talking about, for example, setting up studies in college dormitories, for example, which might be where there's close contact, perhaps a high risk of transmission, and seeing whether the vaccines reduce transmission there. So I'll say it's a very important question. We don't yet have the answer to that. I suspect that the vaccines are going to have some impact on transmission, but we just don't know the magnitude of that and whether asymptomatic infection is common. So we're going to need more studies going forward.
Thanks, Phil. Another great question, and one that I think both of us hear quite a bit. For those who already know they've had COVID-19, they've already tested positive, should they still get vaccinated?
Yes, this is a commonly asked question, and it's going to be even more frequent, I think, as these vaccines roll out. What the general recommendation is now is that yes, despite a prior history of having a documented COVID-19 infection or disease, individuals should get vaccinated. And again, it's going to occur in phases based on priorities. The reason why we say that is we do not yet know, how long the duration of protection is after actually wild type infection or natural infection and vaccination. There's no evidence to think that vaccinating someone who had COVID-19 earlier is associated with any adverse events or would have any side effects. So the general consensus now is that individuals should get vaccinated despite any prior history.
Thanks very much, Phil. And we are coming up fast to 12:30, so I'm going to wrap up and thank Jennifer Nuzzo and Bill Moss for joining me today, and also give a big thank you to everyone who joined us and also to those who submitted questions for our experts to answer. This briefing will be archived and it will be available on coronavirus.jhu.edu. And as a reminder, we will be offering these regular 30-minute briefings on Fridays at 12 p.m. And in each briefing, we'll focus on what you need to know right now about the COVID-19 pandemic, and we will have live Q&A with our experts. I look forward to seeing you at our next 30-minute briefing. Until then, thanks and stay safe.